this cartoon, we see the Z disc here, and the M line here. Here, the blue one is the actin, as all of you know, and the red one is the myosin. Here is the head, and that's the tail. And here is where is the titin, springs-like. So the function of this one is to return the muscle to its resting position after contraction. It has very important role. So that helps the muscle to stretch back to its original position. The titin also provides multiple ligand binding sites for other protein like calpain 3, alpha-actin, myosin, and L-theanine. Because of all these combinations, and because it's a large molecule and attached to so many proteins, anything that affects titin may cause a deficiency in the other protein. Eventually give you different clinical phenotype. So far, there was more than 127 TTN mutation in the literature. And all of them are disease-causing mutations. They cause at least 10 disease conditions that may include cardiomyopathy as isolated, or skeletal myopathy, or both, especially in infants. Titin mutation can be truncated mutation, can be missense mutation, can be splicing, small deletion, and insertion. The titinopathy disease, what has been reported or classified two categories according to the inheritance, either autosomal recessive or autosomal dominant. Autosomal recessive, example of congenital myopathies like multicore myopathies and central nuclear myopathy and myofibrillary myopathies are well recognized as a titinopathy. Also, limb-girdle muscular dystrophy type 2J. Early onset myopathy with a fatal cardiomyopathy that was described by Professor Mustafa Saleh, and Emery-Dreifuss disease, especially in children. So when we come to the other side, the dominant part, we found more of cardiomyopathy, dilated cardiomyopathy and hypertrophic cardiomyopathy, and also hereditary myopathy with early respiratory failure, which we are going to discuss in details. There's also the Finnish type, which is called tibial muscular dystrophy, which has been described in Finland. This is a clinical review, one of the largest review in the literature. It's published recently in Annals of Neurology, 2018, from a group in Australia. They looked at 30 patients with titin mutation from 27 families. And they looked at their clinical presentation, they looked at their muscle biopsies results, and MRI of the muscles. From this study and from other studies, I collectively find the clinical features of titinopathy range in some at least of these features. First, proximal limb girdle weakness, which is progressive. Sometimes it stays static until the second decade of life, and then it progresses. Axial weakness. Neck flexion is affected more than extension, and sometimes associated with contraction in the neck. Respiratory insufficiency. They have axial weakness with respiratory difficulty. Scapular winging, described in all the patients. Calves hypertrophy, about 30%, especially in adults. Contractures, biceps, Achilles tendon, neck, and lower spine has been described. Facial weakness, very variable, but seems to be more common in adults. And they have also ptosis, bilateral ptosis. And if there is facial weakness, it's very mild. It may confuse the neurologist with facioscapulohumeral muscular dystrophy. Interestingly, they also may have large tongue and high arched palate. None of them reported with extraocular movement abnormality. The CK typically normal, but could be mildly elevated or could be very high. May reach 23,000. Nerve conduction was normal in all the patients, and the EMG demonstrates chronic myopathic pattern. I found also in the literature very interesting findings in their MRI muscles. The MRI of the muscles may show fibrosis with fatty infiltration, especially in semitendinosus, and peroneus longus. Also, tibialis anterior is affected. In some patients, gluteus maximus and medius are also involved. But interestingly, it avoids the ductus, sartorius, and the gastrocnemius, for a reason that we don't know. The muscle biopsy usually characteristic. In H and M and E staining, you will see dystrophic features in form of fiber splitting, internalized nuclei, and some inflammatory infiltrates. In Gomorrah staining, we see rimmed vacuoles and also cytoplasmic inclusions. The combination of the three is very highly characteristic of this disease. And in the review before, as I mentioned about, they found it in all the patients, even with milder symptoms. Now I will share with you some of the cases that I saw at King Fahd Specialist Hospital. The first one was a girl. She is a daughter of an engineer in Sabah, very high caliber people, very highly educated. She developed progressive proximal weakness and started at age of 10, and she's the only child in the family. At the age of 19, she started to have breathing difficulty. She also had to be admitted to the ICU. IPAP was started, and she did fairly better after that. At the age of 20, she stopped walking for a long distance, and she had to use wheelchair intermittently. The family denied any person with the similar or myopathy or cardiomyopathy. And an examination, I found her having scapular winging. She has also chest deformity, proximal weakness, scoliosis. She has contractures in the biceps and ectalis tendon, and her tendon reflexes were depressed. The CK level was 102, and her EMG demonstrated nerve conduction and chronic myopathy pattern. Echo was normal. I offered her muscle biopsy, and she refused. I asked her to give blood for DNA testing. The second family is a brother and sister. The brother presented with slowly progressive weakness that involved his trunk and proximal part of the limbs. It started around 15 years of age. Also, the sister has similar pattern but milder symptoms. She's older than him by 1 year. Both of them complaining of occasional breathing difficulty. The family history is very complicated. Here is the sister, and here is the boy. Their parents are first-degree cousins. Their dad passed away at King Fahd Faisal Specialist Hospital in Riyadh. He was under the care of my colleague here, my seniors, Sir Said and Kobler. They diagnosed him with cytoplasmic myopathy. And that was actually the clue. Thank you very much. From there, I started searching for it. Because You know, it's difficult. Patient present with weakness and he has breathing. This is we know that all muscle disease, they may have some weakness in the breathing. But few or occasionally you find cytoplasmic inclusions. So from that, on their examination, before that, I will go to the family history. The parents are cousins, as you see here, and after his passing away, the lady got married from his brother. She had 2 kids from the ex-husband, and they both have the disease. Their grandparents, are cousins too. They have remote cousins, a boy and a girl, and both are affected with the disease, and they're still alive. And there is a remote cousin's daughter, or both of them passed away. So, with this complicated family pedigree, I think probably it's either autosomal dominant or semi-dominant. Their examination showed axial weakness, capillary winging, contractures, and atrophy of the biceps muscles and tibialis anterior in particular. Mildly, the calves were hypertrophied. CK was in the range of 315 to 400, and the EMG demonstrated the chronic myopathy. The muscle biopsy was done for the boy, and it showed similar to what has been described at King Faisal report for his father, dystrophic pattern, rimmed vacuoles, and cytoplasmic inclusions. You know, one of the problems too, when you face a patient who has a family a member who died from the same disease, you need to be very careful when you reach the diagnosis, because they will be too much depressed, and it will affect the whole family. The differential diagnosis with this presentation was hereditary myopathy with early respiratory failure. The second differential diagnosis was late onset Pompe disease. Limb girdle muscular dystrophy type 2A were also considered. Collagen 6 related myopathies because of the contractures, and Emery-Dreifuss disease also considered. And finally, congenital myopathy, which is a boom of disease that we have to think about. The DNA testing using PCR and Sanger sequencing showed apparently homozygous mutation at 119, fibronectin 3. And this mutation is well known to cause hereditary myopathy with early respiratory failure. It has been described in 2012 in Portugal, and it's well known to disease causing mutation. So now we have no doubt about this. The fourth patient is 34-year-old. She is a girl, and she has proximal weakness, but no breathing difficulty. She started to have the weakness at the age of 12. Her disease not progressing badly, but at the age of 18, she stopped walking for a long distance. She has only one brother, and her parents are cousins. Her CK was mildly elevated. The echo was normal. She refused muscle biopsy to be done for her. And the diagnosis demonstrated by DNA testing, which showed this rare mutation, actually a novel mutation at the titin gene, and never been reported in the literature. She also has a heterozygote mutation of this gene. So the final diagnosis of her was limb girdle muscular dystrophy type 2J, based on the clinical pattern, based on her family pedigree and the mode of inheritance, and finally the mutation that has been described. So, going back to the literature, and this is why we're discussing this with Professor Saeed. When we look at the old cases reports, we found them very interesting because, you know, the first description was about myopathy with early respiratory failure was in 1975. And then a large group of patients were described under the title of myopathy with respiratory failure and atypical myofibrillar lesions. They found 16 patients. All of them, they have autosomal dominant pattern, and all of these patients, they have progressive disease and has affected their axial muscles, and eventually they did for them muscle biopsy, and they didn't reach the conclusion. And down there, they thought this is probably a separate entity of girdle muscular dystrophy, and genetic testing will help to prove it or to show it in the future. So, yeah, I'm going to finish here. There is another case reports from China about the same mutation that we found, that this patient has no limb weakness, only axial breathing difficulty and axial fibrosis. When reviewing the literature, the conclusion from all of this review is heterogeneous disease, range from mild subclinical phenotype with typical MRI findings and probably muscle biopsy as well. It may progress later with the respiratory failure, while the homozygous disease progresses from the start and affects the breathing and has more rapid progression, more disability. So in conclusion, tendinopathy is more common than what we expect because of the large variety of the clinical phenotypes types of this mutation, and because it affects it's related to other protein that may cause limb girdle muscular dystrophy and breathing difficulty. The presence of REM vacuoles, cytoplasmic bodies, and dystrophic pattern is highly characteristic of this disease. MRI is very helpful and non-invasive modality of investigation that we should utilize more frequently in assessing patients with muscle disease. And finally, I recommend testing for TTN mutation whenever you see a patient with limb girdle muscular dystrophy and breathing difficulty. Thank you.
Assalamu alaikum wa rahmatullah. As my colleague Osama mentioned, Ahmed Bouznada, Assistant Professor at King Abdulaziz University, and at the beginning I would like to thank the Chairman of the SANEM, Dr. Kobler, and Dr. Aisha Sharif for organizing this amazing conference. And today I'm going to talk about muscle channelopathies. And I will make it like case-based approach. So the first case is a 19-year-old man who has muscle stiffness since he was 2 years old. And he has some delay in the milestones as he needed to hold on furniture to walk till he was 2 years old. Since then, he needs to warm up in order to be able to walk. Like first few steps, it will be difficult, then it will be easier. He had mild difficulty to brush his teeth and comb his hair, and mild difficulty to open bottles. He had moderate difficulty to stand up or going upstairs. No other symptoms, no sensory symptoms, no other weakness symptoms. And he has two brothers who has the same problem, and 3 sisters who were asymptomatic. His physical examination, he had myotonia in the eyelids and also in the hand grip. He had normal tone, reflexes were normal, and plantar response was downgoing. But he had some chronic weakness, slightly more proximal, but almost homogeneous, like around 4 in the upper limb and lower limbs. And this is his video, so So we are just examining for myotonia. I'm not sure if this is clear for everyone. And the point of the video to show that at the beginning it's difficult for him to make the grip. And as he repeats this few times, it becomes slightly easier at the end. So now it's easier. He can let it go much easier. So this is called warm-up phenomena, which is very classic for myotonia congenita. And this is an important feature when we also try to distinguish this from paramyotonia. And EMG, I mean, I guess this is just the classic myotonia sounds we found on this patient in almost every muscle. It's like revving engine. يعني كان واحد بيسوق دبابة أو dive bombers. So it's wax and wane. This is also another muscle. The classic myotonia wax and wane or revving engine sounds. So myotonia congenita, the prevalence is less than 1 per 100,000. They look very muscular. The body built like they are, as if they were working out at the gym. And they have muscle stiffness and pain. Usually it's in the chloride channel gene. And they might have transient weakness after exertion. Usually the weakness is not a prominent feature. My case had significant weakness, which more typical for the autosomal recessive, which is Becker's disease. The autosomal dominant usually has no weakness. So one of the ways to diagnose the channelopathies is the short exercise test. So basically, we ask the patient to contract the muscle, usually the adductor digiti minimi, to contract it for 10 to 20 seconds. Then we measure the amplitude of the the motor action potential every 10 seconds till we finish 60 seconds. And we repeat this cycle 3 times. So here, if you know, I'm not sure if we... But the first motor potential is huge or normal, actually. It's 10. You see the mouse here, or is the mouse showing up, or... Right. The last column, the amplitude, the last column is 10, the millivolt. Then the second column, which is after we ask him to exercise the muscle for 10 seconds, it becomes 2.7. So the amplitude dropped from 10 to 2.7. Then it gradually picked up, like the third, it became 2, then 2.5, then 3.4, if you look at the last column. And the waves here, it's look bigger and bigger. Till the last one, it's 60 seconds. So we do the stimulation every 10 seconds. So this is classic for myotonia congenita. And just to compare and contrast, for paramyotonia congenita, usually the drop is more gradual and doesn't pick up quickly. Like here, after 60 seconds, it just picked up back to normal. We repeat this after the cycle again. We ask him to contract. Then it persists, the same picture. And this is the last, the third cycle. And this is important because in paramyotonia congenita, each time, each cycle, it gets even smaller and smaller. And we'll show that later on. So this is again the pattern of the finding in the short exercise. Normally, you don't see any change. In paramyotonia, sorry, in myotonia congenita, this picture, there is drop in the motor potential, which quickly picks up. That's myotonia congenita. In paramyotonia, there is a drop that's So these are the 4 patterns that was just described in the previous slides. So this is the second case, 20-year-old woman. she notes that her body will freeze when she swims in a cold water. If she sneezes more than once, it will be difficult to open her eyes. And she had mild proximal weakness as she needs to bend over when she stands up from the chair. And this is the video, actually. So now she's trying to let it go. It was easy. Now look at the second trial. It's difficult. So it's opposite pattern of myotonia congenita. Paramyotonia, it's the opposite. Like as you use the muscle more, the myotonia get even worse. And it's a sodium channelopathy. Paradoxical myotonia, it means it's worse with activity, worse in the cold, and onset. All myotonia, like myotonia congenita and paramyotonia, the onset should be in the first 2 decades of life. It's autosomal dominant. Sometimes they present only with pain, sometimes with paralysis. And here the short exercise test. If you notice, it drops the CMAP or the motor potential, drop between the first one and after 60 minutes, and doesn't pick up quickly as in myotonia congenita. So that's the difference, and which is the last graph D, like it's continuously dropping down. So usually the management of myotonia, we use mixilitine 150 BID at the start, then you can go up to 300 TID, but you need to monitor the patient with ECG because it might prolong the QT interval. Lamotrigine, acetazolamide, carbamazepine, and phenytoin and quinine, and brokinamide, all of them has been used. There are 2 randomized clinical trials that prove mixilitine works in non-dystrophic myotonia as well as lamotrigine. So now we go from one end of the spectrum to the other. It's almost, they share the same channel mutations, but as in life, too much of anything give you the opposite. So too much of influx of sodium will give you myotonia. However, if that influx is even becoming more, that will give you paralysis, unexcitable membrane. So hyperkalemic periodic paralysis, it usually, they have shorter attacks than hypokalemic. Usually it's 2 hours or less, but it could be up to 12 hours. More frequent attack, 16 attacks of paralysis per month on average, and they are triggered by fasting and rest after exercise, potassium rich and food rich in potassium, and 75% of patients has myotonia and EMG. And it's the same channel or sodium channel that cause paramyotonia congenita. So most patients, they might have both paramyotonia congenita as well as hyperkalemic periodic paralysis. And usually they have normal strength till they become more than 40 years old. Then you get the fixed weakness, and we will talk about that. These are the criteria. There is like clinical criteria. You have to have 2 attacks, and it tells you that the sodium level should, sorry, the potassium level should be more than 4.5, and you have to have family history, and then 3 out of 6 features. Onset in the first decade, and the duration of the attack less than 2 hours, and there is positive trigger, usually stress or exercise, myotonia, and positive long exercise test. And that will lead us to talk about the long exercise test. The one that we talked about is the short, now the long. So basically, here is the description. You ask the patient to exercise the abductor, the digiti minimi, the ADM, for 5 minutes. So they contract for 15 seconds, then they relax for 3 seconds. Again, for 15 seconds, till they finish 5 minutes. And we measure the CMAP amplitude every minute. And usually you get decrement more than 40, but if it's more than 20% drop in CMAP amplitude, that's positive. So again, this is for hyperkalemic periodic paralysis. The mouse is not showing up here. The first amplitude is small, then it will become bigger in the second attack. Then it's gradually drop, like after 10 minutes, it is smaller, 20 minutes, smaller. Then at So the, maybe just to emphasize this again, the hyperkalemic periodicals, they have this phenomenon that you look at 2 seconds and 1 minute, it's bigger than the first one. And you see that with hyperkalemic periodicals. In hypokalemic, you don't see this increase in CMAP in the first and second line. You just see the drop. And here again, the same. This is hyperkalemic and this is hypokalemic. You just see the drop, but here you see increase in CMAP at the beginning. So the treatment to reduce the paralytic attack frequency, but you ask the patient to eat more regular meal, high carbohydrate and low in potassium, avoid strenuous exercises, and emotional stress and cold. And actually, the stress is a major trigger. Like there are several cases published that the first attack actually happened if the patient heard that someone he loves or he or she loves has died. That's the first. So it confuses people a lot with psychogenic disorders. And the few patients I have seen with periodic paralysis, stress seems to be a very major factor, and it's one of the criteria that you have attack precipitated by stress. In order to avoid paralytic attack, you need, again, high carbohydrate foods like candy bar, and you can use beta adrenergic agonist inhaler. And for severe attack, you might give glucose or insulin. If there is myotonia, we use mixilitine or ticanite. So then the next disease, 19-year-old man with acute generalized weakness for 1 day duration. Woke up with diffuse weakness, no anti-gravity strength in the arm, and unable to get out of the bed. And this is very classic for hypokalemic periodic paralysis. No other symptoms. These diseases doesn't affect bulbar or facial muscles or ocular muscles. And that's very, very helpful feature to distinguish this from psychogenic disorder. No sensory symptoms. And no recent travel, no recent illness. Anyway, the patient has been diagnosed with GBS because had similar attack 1 year ago and was in bed for 2 days, so he received plasmapheresis. The examination showed mild proximal weakness more than distal. Actually, not mild, significant. And the patient is areflexic, which is usually happen during the attack. Areflexia during the attack. But no sensory symptoms. And the lab shows the low potassium level, high CK, which is classic during the attack. The CK mildly elevated, and the TSH was normal. So the patient received the potassium supplement, and he was back to normal within 2 days. So the hypokalemic periodic paralysis, usually longer attack, more than 2 hours, unlike hyperkalemic, typically 12-hour duration, and the potassium level, in the criteria, it should be less than 3.5, but usually less than 2.5. They might have proximal weakness, and it could be due to sodium channelopathy, SCN4A, or calcium channelopathy. And the precipitating factor, as we mentioned, it's the strenuous exercise for both hypo and hyperkalemic. High carbohydrate diet, it's help you to know that it's hypokalemic, because if it's hyperkalemic, high carbohydrate diet is protective. Alcohol, emotional stress, viral illnesses, lack of sleep, and medication like beta agonist, corticosteroid, and insulin, which is the opposite for hyperkalemic periodic paralysis. And this is just a reminder that this is not for this is the same picture I showed you for the hyperkalemic, but again, at 2 seconds, at 1 minute, you see the increase only in the hyperkalemic, not the hyperkalemic. Muscle biopsy shows vacuum, as you see here, and also shows biometric features, so around 5% drug variation, and you might see tubular activity. This picture doesn't show the tubular activity, but these are the criteria. You have to have 2 attacks with potassium and 3.45, and you have to have family history and 3 out of 6 features. So usually the electroreconnaissance sits within 70% to 80% of the cases in hyperkinetic paralysis. And treatment to reduce the diuretic effect frequency with low carbohydrate diet and sodium restricted diet, avoid precipitation factor like high carbohydrate and strenuous exercises and stress. Medication to reduce attack frequency, carbonic antagonist inhibitor, which is acetazolamide mainly, and potassium diuretic like spironolactone and potassium supplements. To avoid the attack, you might give potassium. And you avoid glucose or sugar during the attack. So, hyperkinetic it might cause permanent weakness sometimes, because, like in order for the muscle membrane to be excitable, the resting membrane potential has to be around minus 90 millivolt, or between at least 70 to minus 70 to minus 90 millivolt. In these patients, most of them, like, they are in the lower range, like 70. If the membrane resting potential become less than 60, it will become unexcitable, and that could happen in large proportions of the muscle fibers. And if that's happening in large proportion of the muscle fibers, the resting membrane potential is less than minus 60 millivolt. That means there is more intracellular sodium, and that's causing edema. So here we can see this in the second row. The muscle looks edematous. White signals means edema in the muscles, and if you get the edema, they get bigger. And why does edema? The sodium goes inside and stays inside. And as we know, like the water molecule or the hydrogen molecule follow the sodium. So these are just cases where the treatments with, for example, potassium might reduce the edema, like here the muscle are edematous, and after treatment the edema is less, and they can resume ability to ambulate again. Last two slides, this is just very famous. The criteria for ambulation, which is basically the unit paralysis plus microglia small chin and hypercolorism, increase the distance between the two eyes, and clean care, little finger, prolonged QT interval of the ventricular arrhythmias, and tubular aggregate. These are the criteria for this ambulation syndrome. I mean, for the reason that this is very famous. And then the last thing, the thyrotoxic paralysis, you also need to have both thyrotoxic causes, hypokalemia and genetic susceptibility, which is mutation in potassium involved in the fibers. And the clue to the thyrotoxic paralysis is in the third and fourth decade, unlike the hyper and hypokalemic paralysis has to be in the first and second decade of life. And it's more common in Asian population. And treatment, you have to treat the thyrotoxic causes. And thank you very much.
Thank you very much. I thank the organizing committee for this conference. Actually, I was also here 13 years ago. Professor Anthony reminded me we were with Professor Kopler and Buhliqa in King Fahd Specialized Hospital, Riyadh, and it was also a very wonderful neuromuscular symposium. Function F5. Okay, thank you so much. So today I would like to talk about a cohort of Duchenne-Becker muscular dystrophy in Egypt, as we did molecular and pathological study. Duchenne muscular dystrophy, as we already know, is the commonest type of muscular dystrophy with X-linked inheritance, affecting 1 in 3,500 live male births. So the most important is the clinical phenotype. He's usually a boy with delayed motor milestones of development in most of the cases, has proximal weakness of both lower limbs before 5 years of age with calf pseudohypertrophy. And this is followed gradually by weakness of trunk muscles, muscles of both upper limbs, and until the child will lose ambulation before the age of 12 years. There may be associated cardiomyopathy, mental retardation, behavioral changes in some patients. And the natural history, usually these boys, as we already know, die before 20 to 25 years of age by respiratory or heart failure. So this is a natural history, and now we want to take more importance to the very early diagnosis of Duchenne with minimal or no symptoms before the condition will progress until he will be wheelchair affected. At these minimal symptoms, we can give the new therapies, and we can get benefit of the new therapies. And this is a dystrophin gene, as we already know it. It is a big one of the biggest genes in the body with 79 exons. And also we know the dystrophin protein and dystrophin-associated proteins. The most important are the sarcoglycan complexes in the top. When dystrophin antibodies, when dystrophin protein, the carboxy terminal or its rod domain or amino terminal will affected, the sarcoglycan complexes will also affected secondary to it. So the diagnosis of a dystrophinopathy patients depends on the clinical phenotype. The most important, even after you do a sophisticated genetic study, the clinical phenotype that we presented is the most important. This is followed by laboratory diagnosis, and as we know, the serum CK must be in thousands, then the nerve conduction and the myogenic EMG, the echocardiography, the genetic testing. First, 20 years ago, we were doing the PCR to detect hotspots, and we all know now this became obsolete testing. Now we all refer to the multiplex ligation probe amplification, the MELPA or the MLPA. Then the dystrophin gene sequencing, or now we do the next generation sequencing to the dystrophin gene, and this become a very important testing for, in dystrophinopathy. The muscle imaging also can add a lot, like muscle ultrasonography, the CT muscles, the special pattern in CT and MRI muscles for Duchenne and Becker muscular dystrophy. Muscle biopsy is still an important method, and the histochemistry, immunohistochemistry, and the Western blotting for detected quantity of protein is also important. In this series, we studied patients referred to the neuromuscular unit, neuropsychiatry department, Faculty of Medicine, Ain Shams University, Cairo, Egypt, in the last 2 years. We studied 111 dystrophinopathy patients who were molecularly diagnosed. So I will present, will grow up. Usually the child came after 7 or 8 years. We found this marked atrophy and marked affection of upper limbs, and this marked deformity and scoliosis, and marked difficulty of walking. This is for the Duchenne. While Becker, we usually found not all the children, but most of them will still ambulant after 12 years old, and usually they have this marked pseudohypertrophy of calf and thigh muscles. So of these 111 patients, we had 11 female manifesting carriers. And the most common group of patients, of course, was that from 5 to 10 years. and other groups were presented. And the most important is the early group, from 0 to 5. This is about 11%. And this is important when you will start to give the emerging therapies. So this usually a brother of affected patient or affected patient in a family with well-known patient with dystrophinopathy. So to detect Duchenne or Becker is very important early. And this is the clinical phenotypes, as most of the patients were Duchenne muscular dystrophy. We have Becker in less, 81 were Duchenne, Becker were 11, and this intermediate Duchenne or Becker were 10. And also we have these female carriers manifesting with symptoms. So the total mutations of patients in this series, we found large deletions in 55, large duplication in 7, and deletion in 1 exon and duplication in 2 exons. This was 1 patient. Also, we found that intron 11 deletion was present, and this is not a common mutation to cause Duchenne muscular dystrophy. It was found in 3 patients. And also, as we found this series, the small mutation were found in 45 patients. Of course, this is not the usual, because less than 30% is affected by the small mutation. But because we became a referral center, and PTC company offered the next generation sequencing free, so other centers refer to us the patients with non-deletion duplication in MLPA. So now we have a large number of patients with small mutations. And this is the frequency of large exon deletions of these patients. And of course, the most common large deletions were about around exon 45, 50, 51, 52, as the other series presented. And also the duplication, the most common here was around 17 and 20. This is a frequency of large exon duplication, around the duplication of exons 17, 18, 20. And this is the frequency of point mutation, and what it was a surprise to us to find 24 patients of the 45 have nonsense mutation. Previously, when I started this work 2 years ago, I thought I will not find a lot of nonsense mutation, but I was surprised that we had a lot of families with nonsense mutation. I did also in another work, but not presented now, the NGS to the carriers, or the expected carriers, the mothers and the sisters. And we found a large number of nonsense carriers, and this was very important. Other mutations affecting these small deletions or missense mutation. And what is important also is we can find more than 1 type of mutation in the family. We can find more than 1 mutation. So this next generation sequencing in an accurate and accredited laboratory became mandatory. And this, my first diagnosed patient with nonsense mutation. It took about 7 years to know that this child has nonsense mutation. Of course, I did the clinical phenotype and lab, and then I did for him the EMG. He's sure Duchenne. Then I did for him the MLPA. I found no deletion duplication. So I did for him the muscle biopsy, and he was definite Duchenne by absence of the dystrophin protein. Then I lasted 4 years until I could do sequencing of the dystrophin gene for this boy. Of course, half of my patients lost ambulation until I discovered that they have nonsense mutation because we don't have the next generation sequencing, especially of dystrophin gene in our country. And of course, because it is very expensive, so the government will not cover this expensive study. And here, this table, it is slightly complicated, but what is most important is that in 4 patients, after they have no deletion duplication in MLPA, and I did muscle biopsy, I did immunohistochemistry, these 4 patients were definite Duchenne or Becker, but after we did next generation sequencing, we didn't find any mutation. And this is very important, as we were already discussing this. There may be mutation in the introns, small mutations in the introns. So these patients must do expanded sequencing, classic sequencing of the dystrophin gene. Also, the affection may be in the protein itself. So they need, as Professor Anthony told me, they need RNA sequencing, and this is, of course, not in every center. It needs a specialized center. So still, the clinical diagnosis is a cornerstone of the diagnosis, even if next generation sequencing or whole exome sequencing didn't show us any variants. And this is a skeletal muscle biopsy we do in our unit. And of course, early you can find a very, very little changes, as either very few necrotic fibers or very few regenerating fibers. And when it is advanced, it is easy to diagnose by this marked fibrous tissue and fatty tissue infiltration. And still, the immunohistochemistry is very important. When you do the most important is the fluorescent technique, and you find that in the normal control, you can find this staining, very nice staining, and in the Duchenne patient, you cannot find any fibers affected. And this, of course, the faint and patchy of Becker muscular dystrophy staining. But what is observed also in this series, and I'm still studying my muscle biopsies, is that when we found a patient with Duchenne, and we found that the dystrophin protein is totally lost, as in the first patient or the second patient, there is no staining in regards to control or other staining of antibodies, you usually expect a large exon deletion. But some of the patients with a nonsense mutation, there is still staining of dystrophin protein that was mistaken by me that these are Becker patients. But when do the nonsense mutation and the clinical criteria of patient, we found they are Duchenne. So it looks like there may be some differences in muscle biopsy between this large exon deletion or nonsense mutation. And this is a muscle biopsy of our first manifesting carrier. And as you see, if you can see it, there is a mosaic staining. There is fibers affected as a mosaic appearance. Some preserved the protein and some lost the protein. And on the right, you can find the bar of the Western blot. Western blot is very important to know the quantity of protein. The dystrophin band in the top, as comparison to the control, is absent. And this one was our first manifesting female carrier. So I put a new diagnostic protocol in our department. We do the clinical phenotype, whether Duchenne or Becker or a manifesting carrier. Then I do serum CK level. Usually in the patients, in Duchenne, it is in thousands. In Becker, it is less. In the female carrier, it can be mildly to moderately elevated. Then we do the genetic test. We took a blood, and we study for MLPA. If you find on the left side a deletion duplication, this is a confirmed diagnosis. As you observed, I don't do any more electromyography to the children. Some of my colleagues, they want to do EMG to prove that he is myogenic. I don't do, and they repeat the EMG to see the deterioration or the power. Of course, this is not helpful in the diagnosis. So I don't do EMG anymore in these patients. And then if there is no deletion duplication, I have two choices. If the test is available to me, I do the sequencing. Directly, I do the dystrophin sequencing. If he is confirmed diagnosis, I don't do muscle biopsy. But if it is not confirmed diagnosis, I do the muscle biopsy and immunohistochemistry. If he is not Duchenne, I go to other genetic study. But if he is Duchenne, still I have these 4 patients, and they are waiting for sophisticated genetic study. So as a conclusion, the diagnosis of Duchenne-Becker muscular dystrophy is still challenging due to the large size of the gene and the occurrence of many mutations. The clinical phenotype, X-linked inheritance, high CK level are the cornerstones in the diagnosis of Duchenne-Becker muscular dystrophy. The confirmed genetic diagnosis and accurate deletion of the type and site of mutation of dystrophin gene became mandatory for the recent therapies and genetic intervention. Thank you so much.
Okay. Good morning, everybody. Thanks very much for this very kind invitation. I would like specifically to thank Professor Bolega, Professor Kupler, and Professor Al-Sharef, and the whole steering committee to have invited me, and I'm very happy to be here for the first time in Saudi Arabia. I hope that the collaboration between our centers will be reinforced from these repetitive meetings here or in Italy. Then my role is to discuss about Pompe disease, and you know that this is my disclosures. It's a very rare disease, but not so rare as we thought in the past. And studying it during several years, we have now the certainty that it's not only a muscle disease, but it's a multi-system disorder. And I'll try to show you the most relevant new discoveries about this disorder. So we said at the beginning that it was a muscle disorder, and it is, because muscle pathology is the prominent pathology in those patients, but also there are several other organs and apparatus that are involved. One of these is, for example, the heart, and we did some studies on a large cohort of 74 members with late-onset Pompe disease a few years ago. And what we found was that 13% of them had a cardiomyopathy, and till that time, the heart involvement was mainly attributed to the children, but also as you can see, other authors, French authors and others, have discovered that also heart is involved, and this is one of the other organs. Also, gastrointestinal apparatus is involved, and you can have some symptoms like diarrhea, constipation, and in some cases, it seems that those symptoms were relieved by the replacement therapy. Also, genitourinary manifestations have been described. For example, stool urgency and urinary urgency, and there is a large number of patients that have been studied in the States, and they demonstrate that also this apparatus is involved. Blood is also involved, and this is a very interesting aspect, because when you study the leukocytes, you can find that several vacuoles are present in leukocytes, and we recently wanted to study the leukocytes of a large cohort of late-onset Pompe patients, and what we found was that compared to healthy individuals, but even to other patients with different kind of glycogenosis, the presence of vacuoles in Pompe disease is very, very suggestive of these disorders. You can see that there is a control, and you don't find any vacuole, but there is also an untreated case of late onset Pompe disease, and you can see that the cell is surrounded by several vacuoles filled of glycogen. And if you look at the other slide down, you can see that after a treatment, these vacuoles virtually disappear. But going back to the most well-known areas involved in muscle, we know that muscle Pompe disease was considered for a long time a muscle or pure muscle disorder. And we looked at this because we started 2 years ago an Italian registry for muscle glycogenosis. And in this registry, we had recorded at least 120 patients with Pompe disease, and you can see that the map of the different centers involved. And what was really surprising was that in this group of patients, we had a delay in diagnosis that was about 5 years. We thought more. Rather than in McArdle disease, where the delay is really longer, you say at least 12 years. This was one of the observations. Another observation came from the fact that the major symptoms, as you can see in that scheme, are not only the muscle weakness, but even fatigability, myalgia, and of course hypercikemia. So keep in mind this kind of symptom, because not rarely the onset of the disease is characterized by hypercikemia, fatigability, and myalgia with no muscle weakness. And here you can see the most relevant muscle groups, and we all know that the lower limbs are more affected rather than the upper limbs. But another point, very important, is the respiratory involvement. The muscle respiratory involvement, you can see that you see a normal presence of a diaphragm, where on the other side there is a raise of lungs because the diaphragm is very weak. And if you look at the other slide, this was a study we did a few years ago with the radiologists, and you can see that there are 3 different patterns down. One is the expiration-inspiration, which is normal. The second one is in a patient slightly affected, where there is a sort of overlap, but the third one on the right-hand side, you can see that there is a complete overlap of inspiration and expiration. This means that there is not enough respiratory capacity. Other musculoskeletal disturbances, you see that in the last years have been mentioned several cases with rigid spine syndrome, apart from scoliosis, osteoporosis, and other spine abnormalities. This is a case that has been described from an Italian group a few years ago, and you can see that this is the typical progressive limitation on flexion of the neck and the trunk that goes to a rigid spine syndrome, which is very well represented. I don't see it very well, but is very well represented in the MRI. And another surprising aspect is the osteoporosis, which is present, we know is present in late onset Pompe disease patient, but also the spontaneous fractures that happen to this kind of patient are not so rare. Just to continue, the last studies we have done were concentrated on the, on the brain. So we started a few years ago in a cohort of our patients, and we found 2 patients with leukoencephalopathy. We want to study more deeply this specific aspect. And in the second paper, we had the chance to study the intracranial arterial abnormalities in terms of, you can see also has been studied in other countries, in China, and another group that demonstrated the cerebral strokes. But we did a larger study, and we found that the presence of aneurysms and of dolichoectasia in the vertebrobasilar artery, you can see here some examples, were much more elevated rather than in the common population. And even more surprisingly, there was a lacunar encephalopathy in the majority of those patients, irrespective of the age, because we had the similar features also in patients with 30, 35 years old. And we also studied the functional MRI in this patient, and this is the summary of the data we had from this study. So you can see that vasculopathy is present in 57% of patients examined, that the dolichoectasia is present in about 52 patients, and the functional MRI showed that decreased brain connectivity, especially in specific areas like middle and superior frontal gyrus, and there was let's say half of the patient mild impairment in executive functions. Talking about diagnosis, we also had the chance to study about 1,000 of patients a few years ago with this LOPED study that were enrolled because of hypercemia or hypercemia and proximal weakness with no diagnosis. And this took us to generate this kind of algorithm. You can see that the dried blood spot is in the center of this. It is a very important passage to suspect and to have a more idea about the Pompe disease. I would like to outline that DBS is not diagnostic, but can generate some other confirmation with other biochemical studies and genetic studies. And this was also realized when we studied about 500 patients with proximal weakness with no diagnosis. Pompe disease was the 4th cause of unknown diagnosis. So this is the last part of my talk, and I would briefly discuss about the therapy. This is one problem always, is that when we have to start the treatment, the enzyme replacement therapy, you know, this very famous paper was the first paper that started the treatment earlier in US, but after 2006 also in Europe. And a few years ago, Benedict Chosa and I, we reviewed all the literature, studying all the patients treated, and we found that at least 2/3 of the patients benefited of the ERT. This was well expressed in the 6-minute walking test, and you can see that there is a defined positive situation, and also in the study of FVC that was in some cases improved, but the majority cases showed stabilization. And we have redone the same study 4 years later, and enlarging the number of the observations over 400 patients with late onset form. What we found was a similar situation, so improvement in motor function and stabilization respiratory functions. This is summarized in this slide, as you can see. And as I would like especially to outline that ERT is also associated with survival, and there are some positive prognostic factors as female gender, younger age, better clinical condition, and early start of ERT. And finally, I would like, because in that slide I outlined that we do not have much longer studies. And last summer, we wanted to look into our Italian population on pompe disorders. We recruited about 180 patients, and what we found was that this is a very new observation, not already published. And what we found was that the persistence of the effect of ERT was over 10 years, as you can see, either for the ambulatory status or for the respiratory status. So we were always convinced that after 3 years there was a decline, which is partially true. There is a decline, but still in the years, over 10 years, there is still an efficient response to the drug. And for this reason, so try to regulate the use of ERT or not. We published with the NMC and the EPOC group, so the European group for pompe disease, this kind of suggestions when to start and when to stop the treatment. And this is the very last part. So you know that there are, as in Duchenne, as Andoni showed and other colleagues showed this before my talk, there are several other attempts to find an improvement of the therapy, either from the pharmacological point of view, but also from the genetic point of view. And this is the last one we are now ongoing, and is very close to be finished. Only 11 patients needed to close the study. And this is the possibility to have a better molecule for enzyme replacement therapy. And this is called NeoGAA, and the study is called COMET. And the NeoGAA differs from the old one, let's say old one, but still valid, because he has additional M6P residues on the surface, which increase then the uptake of the GAA in the cells. And this is I don't want to go deep in these details, and this is the design of the study. And here all the countries involved, and we hope to have in 2 years better results. So in conclusion, pompe disease is a multi-system disorder. It's not only a pure muscular disorder, and there is a wide clinical and genetic variability. There is an involvement of several tissues, and this has to be looked for, because sometimes some areas are neglected, and a very large workup, diagnostic workup, is needed. And we are all sure that an early diagnosis may favor an early treatment when is really adequate. And from the literature data, we know that 2/3 of LOPT patients might benefit of ERT rather than being untreated. And this now, with our new data, seems to be a very long-lasting effect in the years. So this is the group, the place where I work, Messina, and the group of the European researchers for pompe disease. The other one is our group and our collaborations in Italy and in Europe, and extra-European collaboration. And I would like to thank you all for your attention.